Welcome. We are having a conversation today about a medication that many of you have been hearing a lot about recently called mifepristone. And you've been hearing about it in the context of the debate on access to medical abortion in America. Many of you may not know what mifepristone is, and so we thought that it would be an opportunity for an endocrinologist, my colleague Dr. John O'Day, and myself, Jennifer Lang, I'm a gynecologist, to sit down together and discuss what this medicine is, what the potential uses of it are, and a little bit about what the current controversy over its approval by the FDA involves, and how that controversy might play out in the doctor-patient relationship and our ability to practice the best possible medical care that we can. So, John, do you want to start by explaining for someone who has just heard this name but maybe doesn't understand what mifepristone is, how it works in the body, what its potential uses are, its current and potential uses, and just tell us a little bit about your own experience with this medication.
Mifepristone was developed originally by a guy called Beaulieu in Paris. And I don't think he had any intent on making it an abortion pill. It was simply a steroid chemical, and he was a steroid chemist. And to best understand it, we should talk about the role of progesterone in an oral pregnancy. During an oral pregnancy, progesterone secretion becomes more and more generous. And this causes the lining of the womb to thicken, which gives the ground on which the uterus can grow and nourish. And it does so by stimulating progesterone receptors that are located in the lining of the womb. And so mifepristone, because it blocks progesterone receptors and is therefore an anti-progestin, tends to cause an atrophy of this lining, and you lose the ground, you lose the fetus. So if you think about it, the mifepristone is not attacking the fetus per se, but rather altering the sustaining ground on which it lives. As a result, passively it floats away. However, mifepristone has far more important roles throughout the rest of the body, which is what we're always been talking about, the idea that we should look at women's health care in a less sexualized manner and more in a broad sense of the effects of hormones on the entire female body.
Okay, so in your practice as an endocrinologist, what other applications has this drug, mifepristone, been used for?
Well, first of all, then, desexualizing things.
Mm-hmm.
Progesterone has other effects than simply sustaining the uterine lining. And so it appears to have effects on a variety of cancers and on immunity and immune surveillance. Beyond that, mifepristone also blocks a different kind of hormone known as cortisol. Cortisol is an adrenal steroid, and it's the foundation for our stress response machinery. That's important because pretty much every one of the complex diseases in humans is sensitive to the stress response machinery and can be triggered, diseases can be triggered by disruptions of that machinery. Think, for example, depression, major depressive disorder, for example, or even a psychotic episode can be often triggered by stress. Similarly, immune disorders such as rheumatoid arthritis. These are sensitive to the sex hormones and to adrenal hormones. Mm-hmm. That's why during pregnancy, many women can throw away their arthritic pills for the 9 months. So mifepristone blocks cortisol the same way. And therefore it can be used to recalibrate the stress response and as a result influence widely all kinds of disorders that are stress sensitive.
Great. So you are in the midst of preparing an application for a clinical trial that would look at mifepristone for something completely other than abortion. Can you tell us a little bit about that?
What we're looking at is because mifepristone has a profound effect on the stress response, and because cortisol and estradiol are important regulators of inflammation in the body, natural regulators, I might add, far more potent than any kinds of monoclonal antibodies that are being used at the moment, that these could be harnessed to treat some of the autoimmune inflammatory disorders, specifically the neurodegenerative disorders, Parkinson's disease, Alzheimer's dementia, ALS, multiple sclerosis. And these conditions clearly are hormone sensitive, and the inflammation that mediates them is hormone sensitive. So that's where we're looking at, using low doses.
It's fascinating and something that I feel has been completely absent from the press coverage of this issue and the general public debate that we're having. We're thinking of mifepristone just in this isolated view that it's got one use only, that's for abortion. And so if you're anti-abortion, you should be anti-mifepristone. But if you're anti-abortion, are you also anti drug development for Alzheimer's disease, for Parkinson's disease, for Cushing's disease? There are implications far beyond that I think it's important for us to think about and consider.
It's ironic, really. You think about it, they're trying to restrict the use of mifepristone, when the exact opposite should be happening. We should be opening up the use of mifepristone in a host of other illnesses, including a variety of cancers and neurodegenerative diseases and inflammatory diseases, but we're doing the exact opposite. Why are we only hearing about that now? Because for years after mifepristone was developed in France, it was blocked from being developed and released in the United States, probably because of the effects of religious attitudes. I've wanted to deal with this drug for years and not been able to because of bureaucracy.
This is a really interesting conversation for us to have because you just brought up religious attitudes and you were raised Catholic. And I mean, your feelings on abortion are perhaps different than mine. I was not raised with religious feelings, and I am a practicing obstetrician gynecologist. So do you want to talk about the role of religion in science and how we got to this place in the first place?
Well, my religion is endocrinology.
Oh, okay.
And I was raised Catholic, and I was raised to the idea that abortion was wrong. And I have some mixed feelings about it now. On the one hand, I think the importance of the individual is prime. And so one is not just eliminating a fetus, potentially one is eliminating a person. Who knows? But that's not my job to worry about, or nor yours for that matter. Mm-hmm. That's for ethicists, if there can be such an effective thing. And so I think I'm objective about this in the sense that I'm not running in favor of mifepristone simply because I believe in abortion, because I don't. At least certainly not a frivolous abortion.
Okay.
Perhaps in conditions such as rape, or if there's a fetal abnormality like an anencephaly, of course you should have an abortion.
Okay, well, we disagree on this point.
That's fine.
However, what I think we both agree on is that as physicians, it's our primary responsibility to offer patients the most safe and effective treatment for a given condition. Would you say that that's true?
That's not. We're not even talking about our rights. We're talking about the women's rights. Women have the right to want and to get the kind of health care that they have a right to and deserve. Mm-hmm. And this should not be interfered with by people with heavily religious agendas. What if I'm not a Christian? How dare you interfere with my ability to exercise my right as an individual to control my own body?
I agree with you there. How dare you? So what happens when a regulatory agency such as the FDA reviews safety data, reviews studies, and agrees to approve a drug and bring it to market in the United States, and then a court 23 years later, issues a decision indicating that this medication should be removed?
one has to question, and it's obvious why.
Mm-hmm.
They cherry-picked a judge who has strong anti-abortion feelings, I presume on a religious basis. This is supposed to be democracy. We're supposed to have judges that represent this pluralistic society in all its mixtures. It reminds me of John F. Kennedy when asked, would he be a Catholic president? He said, no. As John F. Kennedy, I'm a Catholic. But as President Kennedy, I don't have a religion. Mm-hmm. And that's the way judges should be. Mm-hmm. Mm-hmm. The whole principle here is that people should make decisions based on facts, data, information, and should do so in a measured manner that depends on their ability to understand what's going on. And if they don't understand it, they have recourse to talk to experts, and there are plenty of experts in this field.
So what are the facts and safety data on this medication that's been available since the year 2000 and, in Europe far before that? Is this a dangerous medication? Is this a medication that's causing people to...
The data are enormous. Mm-hmm. I've used this drug myself in mm-hmm. people for having nothing to do with abortion. In terms of side effects, it can alter potassium levels rarely, but it can at high dose. And so we monitor potassium levels in those whom we're treating.
Would you consider the single use of a single 200 milligram mifepristone tablet to be a high dose?
Hell no, and it's only one time.
Exactly. Whereas
there's no way it could mess up with now. Again, when I use mifepristone, I may use one every other day or 1-3 times a week for months on end, and I have.
That's right.
Which is a completely different scenario, higher dose. 200 milligrams of mifepristone, in my opinion, is absolutely innocuous. The whole idea that it could mess people up, one single dose, that's ludicrous.
Thank you. Yes. And so from a scientific perspective, there is really no indication that this
idea is absurd.
I agree. So brings me back to, should a judge with no medical or scientific training mm-hmm. themselves be able to issue a decision that contradicts decades of scientific study and safe use and application in the American market?
I'm sure his name isn't Solomon.
I agree. So I think what we're both in agreement, very strong agreement, is that science, logic, peer-reviewed clinical trials, data collected by physicians over decades of use should be what guides our medical decision-making, not a judge's religious position.
This isn't even complex. Number one, we're dealing with an innocuous drug at this dosage. Use one single time. Mm. Secondly, this drug should be available for a wide variety of conditions that have nothing to do with abortion. So the idea of restricting this drug from its benefits to the population at large is also, it's not just absurd, it's dangerous.
Thank you.
Assuming that in our wonderful democracy, and it is a great democracy, these legal beagles manage to ban mifepristone, what might the consequences be?
Well, in my field, mifepristone has primarily been used as a medical abortion agent up to about 10 weeks of pregnancy. And this has been a tremendous development for the safety, efficacy, and ease of accessing abortion for people across America for the past 23 years. So previous to mifepristone, if a person was pregnant and needed an abortion, they would have to undergo a minor surgical procedure, which involved dilating the cervix, introducing instruments up into the inside of the uterus, and evacuating the contents of the uterus in a surgical way. And like any surgery, this is an invasive procedure that has risks involved, risks of anesthesia, risks of damage to the lining of the uterus. Now, these risks are very, very low if you compare them to, for instance, the risk of pregnancy itself, okay, to the life of the mother, pregnancy can be risky. But all the same, having a medical option for this has made it much less dangerous and much more safe and accessible to people who need abortion care. So banning this medication would be forcing people into a surgical environment when that's not needed, which has a long list of downsides.
Then let me ask you a question from the politician's point of view.
Sure.
What's the difference in cost between a medical abortion and your old surgical abortion?
Medical abortion is much less expensive and much more comfortable for the patient because they can undergo it in the comfort of their own home with their, support system, loved ones present, and avoids them having to make unnecessary trips into a doctor's office or a clinic or a hospital. And so it is a huge cost savings as well as being the best standard of care medicine that we can practice.
I also think as a male, many of us have daughters. Some of those daughters become pregnant.
Mm-hmm.
Suddenly, people's positions politically on things become different when they have a personal experience, I would imagine.
I think you're right. And so I think it's very important that people who have received abortion care in their life, talk about it so we normalize this and we understand that this is something that about 1 in every 4 women in America will undergo in her lifetime, will need to access abortion care. So if we take away this service, we're talking about a huge proportion of the population that is going to suffer the consequences.
So it's very retrogressive.
It's every other country in the world is moving forward on this issue, and for some bizarre reason, America is moving backwards. The United Nations has even commented that this is unequal from a human rights perspective. American women's human rights are being impacted by recent policy changes restricting access to essential medical care.
Why does it seem that religious Republicans think that this will serve them well in the long run? I mean, more than half the population are women, aren't they? Then presumably some of them will become more enlightened, more educated on the subject, and perhaps vote against those who are restricting their rights.
It's a really good point, and in fact, every time this issue is brought to voters, voters show that they want abortion to be safe, effective, accessible, and legal. This is a issue that voters have made their voice heard again and again. Every state that brings it to their population sees that their attempts to ban or restrict abortion gets voted down.
I have to say, I get where you're coming from, even though a part of me doesn't believe in it. Okay. But we're not talking about medicine now. We're talking about my background.
And my feeling is that if a physician is uncomfortable providing abortion care, they just shouldn't provide it. Mm-hmm. If a patient is uncomfortable having an abortion, they shouldn't get one.
Yeah.
But to have policy that is making that decision for everyone without any backing in science, in standard of care, in good clinical care practice makes no sense whatsoever.
So I hope that people who look at this video can see that we have a balanced approach, that we're not on the same page, that in some respects we're coming from two different perspectives, and yet we're kind of in agreement that mifepristone should not be restricted.
at all.
At all.
And I think that it's really important that as we're engaging in this conversation about this drug, we think about the implications for access to any medicine. Can we live in a world where, the religious beliefs of a judge somewhere, are capable of contradicting decades of medical use, or a regulatory agency like the FDA, whose job it is to assess whether a medication is safe and effective?
Mm-hmm.
And if we do that with this one drug, what are the implications for accessing any medication?
Well, remember too that the FDA classically has been pretty conservative.
Exactly.
We can never say that the FDA could be given a hard time for being excessively liberal because it insists on retesting drugs that have been used for years in other countries, and yet they approved it.
Thank you for watching this important conversation. I'm Jennifer Lang. I'm an obstetrician gynecologist, board certified, practicing in Los Angeles, California. And I've been speaking with my colleague and partner, Dr. John O'Day, who's an endocrinologist, also in Los Angeles.
Thank you.
Sweet.